Well, I am thankful to the organizers for calling me here, and I think Charak has mentioned a different dimension for treatment called Yukti. Yuktistu Yojana Yatu Yujyate. Essentially, knowing that there are multiple variables and synchronizing them to find a perfect balance for the person before you. I think Dhara today is a perfect Yukti example where three different government sections have come together and have provided a Yukti Yojana in the form of Dhara, and I'm especially thankful to all of the organizers. And I'm also thankful for the second part that I see in the audience before me venerable senior Vaidyas, Dr. Parvaze sir, tomorrow Dr. Murlidhar Sharma is going to join us, Nambudri sir who comes to the hospital. And I must admit that it's not very common that practitioners who are the interface between society and Ayurveda and what essentially society looks upon as Ayurvedic healthcare are usually not commonly called upon to share their views. And I thank the organizers for the same. So the current scenario is extremely conducive for Ayurveda as mentioned by the Secretary Kotecha sir, and this is primarily because of the increasing awareness of limitations of conventional approaches. There's also, thanks to COVID, an increasing awareness for attaining health and retaining the same, and for that in my private practice in Pune, Mumbai as well as in Bangalore, it is the first time in so many years that we have consistent people coming in for health consultations and not for disease conditions, which is what we are normally in the mode of practice in private practice. So that's a new domain which also involves putting more inputs into understanding ahara as well as vihara and making it suitable to the 21st century person as a part of society and preparing individualized solutions, something which Gurmeet ji referred to earlier, and the increasing demand for Ayurvedic herbs, which is something which I will not be talking about in my talk. So this is my personal experience in Pune, Mumbai and Bangalore, that 80% or more of urban society patients who seek Ayurveda help do not choose Ayurveda as the first resort. They come to us as a secondary choice, primarily because they are aware now of the limitations and they would like to find better choices and be more in command of their health rather than be driven by pharmaceuticals. The second thing is that more and more patients are presenting with multi-systemic disorders, and the reason I refer to this is that the challenges which we face today are things which we need to resolve, and I am thankful that Kotecha sir is here, because our education system, our whole BMS MD curricula is from an era where Ayurveda was the first source of perhaps treatment. And the vision at that time was to make good quality medical practitioners who will be accessible to rural India as well as urban India. But at that time the population of India was rural centric, which is now shifting. And we, even as a student, when I was doing my graduation, post-graduation, was interning with the likes of Nanal Vaidya in Pune, we used to see patients with single disease, single gentleman. We were not adept or we were not exposed to seeing multiple diseases in the same individual, which is referred to as Vyadhi Sankar in the science. And our whole education system is based upon teaching one disease at a time. It's not based on teaching multiple diseases in the same individual. And that's why I say that these are the challenges, that the skill sets of graduates are not market ready. The diminishing availability and to adapt traditional Ayurvedic knowledge to geocultural specificity. Sir referred to Helsinki, but I travel to the US pretty regularly in the last 22 years. We need to adapt, and there are some things which can be learned only by experience. When I started using Gruta Kalpanas in the same volume that I do in India, in the US I found that patients reacted negatively. It's probably because the Gruta molecule is alien to their genetic pool. So the therapeutic dose for them, in my limited experience, was a few drops and not in the volumes that we are accustomed to practicing in India, 30 ml, 50 ml, 250 ml, that doesn't necessarily work. So these kinds of experiences need to be built in without compromising the Shastra, and that's what I refer to in geocultural specificities. Another thing, and I speak this primarily in an Indian context, that we have few private sector indoor facilities, and hence the enabling mechanism of insurance etc. is not yet as strong. It's still stronger since the new government has enabled Indian medicine to be a part of insurance, but it's still not easy. And most important, that there are very, very fewer accessible centers of excellence where a Vaidya can refer for a second opinion. The likes of Nambudri sir, Parveze sir are very rare, and it's not always possible for us to send patients from elsewhere to their place. So we need to also create good centers of excellence, and I will perhaps lay out some of the ways which that could perhaps be achieved. So my firm belief is that better training and better mentoring in the form of CMEs can lead to a better future, and we need better design and adaptation of tools and technology. It was referred to by Kotecha of MI and AI, and I will refer to in the same, as well as simulation centers. So the possible path ahead. So as I mentioned earlier, the BMS and MD program is structured probably around the MBBS and MD curriculum, and it is not wrong per se, but we need to also look at other models. One of the models which has been used in the 60s at McMaster University, it was primarily adapted in medicine, now it has been adapted across various disciplines, is the problem-based learning. And if you look at all the Samhitas and the Adhyayas, the students approach the Acharya asking about issues faced in clinical practice about a particular health issue. So the whole narration is based on problems. So probably the texts were more oriented towards problem-based learning than what we are doing right now. As a sequel to this, what happens is, as I mentioned earlier, teachers as well as experts lecture and share experience on singular diseases and not on multiple diseases. And hence students, when they complete their graduation and they come into practice, they face challenges because they have not been exposed to this kind of decision making where multiple components are there. It's there in the Shastra, no doubt. But being able to see cases, being able to see results is something which matters to that nascent budding Vaidya's mind. And teaching is usually in a classroom outside. If you look at the curriculum, in most institutions, 30 to 35% exposure of the student takes place to live patients in the last year of graduation. Because we have silos of the Ayurveda anatomy department, Ayurveda physiology department, and none of these students ever visit a hospital at all. Whereas actually, there is no reason why a student shouldn't visit a hospital from the first year itself. Some of them might be bored, they might walk out, which they do in any case. But let us at least facilitate the students to interact with healthy individuals and patients from the first year onwards. So can we revisualize our education program? So these are my solutions. We need to engage good experienced clinicians and see to it that students are exposed to Ayurveda algorithm based treatment, Avastha Anurup Chikitsa. And Charak etc. Vagbhat have always said that we need to observe the minutest variables and then devise a treatment, which is essentially algorithm based treatment. We need to reintroduce the method of having honorary physicians who have no connection with the academia but who come in and teach students because of their passion of teaching. Now, at least in Maharashtra, due to some malpractices, that system has been stopped across board for homeopathy colleges, teaching institutes, for allopathy teaching institutes, but that was something which was actually benefiting students of all pathies, having honoraries who come and contribute voluntarily their services and knowledge to students. And we also, perhaps Ayush department could help, collate experience-based writings in various Indian languages. The experience is based on the humble experience gained that when we published B.V. Gokhale, Mama Gokhale's writings 25 years ago, where C.P. Shukla etc. had been to Pune, we struggled to sell the copies that we printed. And when we redid that program on the 100th birth anniversary of Mama Gokhale last year, we were out of supply because young students want experience-based writing and they are not always available in English or Hindi. So we could perhaps do that. An initiative which I thought I should, this is just new. At a donor, a group of donors donated an ICU to the charity hospital where I work. And because of that, my students can see patients up to end care, up to terminal care. So Arishta Lakshanas, etc. can be observed by students in a patient. We get fresh cases of stroke nowadays, which we are not getting because we just didn't have the infrastructure in a charity hospital. And it also helps provide Ayurveda opportunities of Nasya, Basti, etc. for unmet medical needs in an ICU. Some of my colleagues are also doing the same at the Dinanath Mangeshkar Hospital's ICU also, of course with permission and dialogue, which takes time. It doesn't happen overnight, but if you persist, we can certainly contribute even in ICU care. Today's investigations are primarily designed to facilitate allopathic diagnosis, but perhaps using technology, using new sciences like blood rheology, which looks at biophysics of a blood drop, the volume of blood, the viscosity of blood, the amount of ingredients involved in the blood, the time required for it to disintegrate. So we have been doing that in Kaphavrut patients, where we find that the drop of blood takes a longer time to disintegrate. In Pittavrut, it takes a lesser time. These are just experiments, but if we have technology to guide us, we could perhaps come up with newer interpretations of available tools or create completely new. I was happy to see that one of the competition has given a recognition to the menstrual flow analyzer. We need such kinds of ideas to come forth. And all of our training is primarily based on patients, and if at all, because some hospitals unfortunately don't have patients. They have patients only when there is an inspection. And we need to have institutes where students can, if there is no patient available, then at least create a simulation center. And these are just examples of simulation centers elsewhere, and these are used for childbirth, for venesection, for venipuncture, etc. But for Ayurvedic Udar Parikshan, for Ayurvedic Nadi Parikshan, we could create simulation centers given the right kind of tie-up with Vaidyas, practicing Vaidyas, academicians in Ayurveda, as well as experts in that domain. So this is about multisensory labs, etc. These are there in MIT, Boston, and so on. You also have artificial hand, neurosensory tools to do that, and there are new machines which are coming in to help a Vaidya do pulse diagnosis. As I said earlier, Ayurveda students rarely meet healthy individuals, whereas our whole focus, 50%, is on Swasthya. So we should actually be putting more emphasis on taking field visits. We should certainly continue our visit to sanitary departments of government departments, but we should actually also take the students to healthy individuals in grounds and gymnasiums. Thank you. Thank you for again for giving me an opportunity to share my thoughts. Thank you.